Dr. Firoz, just Dr. Mishra sir called me. He's stuck in traffic, so he asked us to start,
Okay, so
not wait for him.
no problem. So I'll introduce his part also, right?
Yes, everything Dr. Deepak's role also will be taking.
No problem. Fine.
Good evening, Dr. Minu.
Good evening, Dr. Minu.
Good evening. Good evening. Hello. Hello.
Good evening, Dr. Lavanya.
Good evening, Shrikant. You're able to hear my voice?
Yes, yes,
Yeah.
you're audible.
There was
We'll-
some.
We are just waiting for a couple of minutes for Dr. Amit Verma. Once he
Sure.
confirm, then we can start on.
Okay, sure.
Hello. Hello.
Good evening, Dr. Amit.
Hi, how are you?
Fine. Yeah, Anita.
Good evening, sir. We can start the webinar on the count of 5.
Okay.
Yeah. We can now start the webinar. Dr. Firoz sir is here. Requesting to take over the session, please.
My voice is audible?
Yes, sir, it is audible.
Hi, good evening, everyone. On behalf of MPAI, I thank everyone for attending this webinar. And I also welcome all the esteemed faculty members and delegates for attending this educational event virtually. Let me take this moment to proudly say MPAI successfully organized series of educational webinars on different topics in the month of July this month. This will be the third webinar which we are conducting in this month, and we are planning few more webinars in the coming months. If we look at the success rate of molecular diagnosis, it differs across institutions, based on biospecimens and depend upon the institute's acquisition and processing practices, in addition to the testing methodology which is being used in the lab. As the pre-analytical errors are the common issues across the country, let us discuss about best practices on optimization of tissue handling, processing in the area of precision medicine. As multiple stakeholders are involved in tissue handling, including interventional radiologists, surgeons, pathologists, molecular scientists, and technologists, increasing awareness regarding biospecimen handling and its associated guidelines are very crucial. Let us understand how we can minimize the pre-analytical errors and essentials of high-quality biospecimens for personalized medicine. If we look at each step in the pre-analytical, all are very crucial for successful biomarker testing, be it sample collection, sample processing, sample transport, and sample storage. To understand more on this issue, I would like to invite Dr. Amit Verma to talk on the topic pre-analytical issues and its impact on molecular biomarker testing. Before going into the details, let me introduce Dr. Amit. He is the founder and CEO, Dr. AV Institute of Personalized Therapy and Research Institute. He is the Chief Medical Director, Molecular Quest Health Services. Dr. Amit Verma is experienced medical consultant with a demonstrated history of working in the hospital and healthcare industry. Skilled in healthcare, clinical research, medicinal education, medicines, and hospitals, he has a strong healthcare services professional with a fellowship focused on cancer medicine from the University of Texas MD Anderson Cancer Center. His passion and vision towards the field of cancer has made him establish two important clinical genetics clinic, namely Personalized Medicine Clinic and Familial Cancer Clinic, which is one of its kind in India. Having a sound background in the clinical and molecular cancer medicine makes him a truly unique physician of the medical fraternity. Dr. Amit Verma is a positively spirited person who loves to spread awareness of cancer genetics among the underprivileged population and the younger generation, where he strongly believes that cancer is preventable, provided appropriate actions are taken in a timely fashion. Over to you, Dr. Amit.
Thank you very much for the invitation and for this opportunity to interact with everybody. And I'm going to talk on the pre-analytical errors in precision oncology, and I will try to share a couple of my personal experiences as well. But before that, we'll just go through a couple of slides to discuss the issues in more objective way. May I have my slides, please?
Just a second, sir. I'm sharing the scene.
Can I have the slides? Yes. So the topic for today's discussion is the pre-analytical issues and its impact on the molecular biomarker testing. Next slide, please. So today's learning objective will be the way in which the specimens are handled and processed is very instrumental in ensuring that specimens acquired from patients are fit for molecular testing. Artifacts which are introduced during the pre-analytical steps of testing may affect the data analysis and render analysis uninterpretable and even preclude analysis altogether. So we'll just try to understand how we can really overcome all these things. And other objectives will be the presentation highlights the importance of controlling key pre-analytical factors to ensure the integrity of specimens for downstream molecular testing, and also recommendations for critical steps in collection, stabilization, and processing of tissue, cytological samples, and blood samples. Next slide, please. So as as a diagnostician, we all are familiar with the different phases of biomarker testing. And you can see that the errors can happen into three major categories: the analytical, the post-analytical, and the pre-analytical. And actually, if you see the sequence of any analysis starts from the pre-analytical, post-analytical, and then the analytical part. So from a clinician point of view, we tend to see only the analytical and the post-analytical errors. But from the laboratory point of view, the pre-analyticals are very, very important. And these are pertinent to the specimen handling, transportation, preparation, and storage. And it is very difficult for us to ensure a uniformity in all these aspects of pre-analytical issues, actually. Next slide, please. If you see, the pre-analytical errors can be categorized into the major four. The first is the sample collection and stabilization, which happens at the clinical site itself, and then the sample processing and the management, followed by the sample transportation from the hospital to the lab, and then the sample storage or archival of the tissue for the future testing. This is followed by the analytical and the post-analytical, which I'm not going to focus much on today discussion, but also these are equally important. Any implications or any effect on the pre-analytical aspect have implications on the analytical as well as the post-analytical outcomes. So we have to be very, very sure that the key important pre-analytical factors are taken into account while we are doing the analysis or the post-analysis for that matter. Next slide, please. As per the data published, almost like 75% of the errors happen in the pre-analytical category. And if I try to categorize them, which I have just mentioned right now, the 5 major steps actually. The first is the time to stabilization. In this particular category, the cold ischemia time is very, very important. We all are familiar with what does the cold ischemia time stands for. That is that after the tissue or the biopsy is taken from the organ or the tissue for that matter is processed or fixed, that time is called cold ischemia time, when there is no blood supply to the tissue or there is no fixation of the tissue. And this is very, very crucial actually. And then the method of stabilization, even the type of fixative used, whether it is buffered normal saline or the formalin, or it is the ethanol, even the time of fixation does matter. And also the volume of specimen does matter in terms of the interaction of the fixative with the tissue itself. And then the third important factor is the method of processing, the type of paraffin used, and also the quality of processor fluids, what kind of other processing fluids which are required, including isopropanol, ethanol, and those things do matter in terms of fixation. And then the specimen management, which happens post the blocks are being formed, especially the section cutting practices. And then the sample storage and transport, especially for the long-term storage and also for the short-term transport on the storage in that particular time duration. Next, please. So as we were discussing about the pre-analytical error in the cold ischemia time, and the ideal time or the cold ischemia time should be less than 1 hour. This is recommended. So as soon as the specimen is taken out from the organ, it should be fixed ASAP. And the idea here is to avoid any degradation of protein and nucleic acid. And the process of autolysis starts immediately as soon as the blood supply is weaned off, and fixation is immediately required. Next slide, please. This is a very important representative slide where the cold ischemia time has been calculated and the impact on the reporting. Here, the phospho-AKT, that is the phosphorylated AKT protein, is being analyzed on the immunohistochemistry on the formalin fixed tissue on colon cancer. And here you can see that the pre-biopsy specimen is showing a lot of phosphorylation of the AKT protein. And as the fixation has been delayed, the expression of the phospho-AKT protein has gone down. The cold ischemia time is very important, especially for experiments where you are treating or diagnosing or identifying the proteins with a very short half-life, especially the phosphorylation, which is being mentioned here. But for various diagnostics purposes, the proteins what we normally use in our clinical practice are quite stable. But when you're talking about the nucleic acid, the cold ischemia time have a lot of implications, especially the degradation starts quite sooner, and we need to avoid the long cold ischemia time for that matter. Next slide, please. The tissue sample must be immersed in appropriate fixative. The ideal fixative, which is routinely used, is the 10% pH neutral phosphate buffer formalin. And this is basically a universal fixative, but at the same time, it has some limitations. It is associated with a lot of nucleic acid degradation, but the quality of the DNA can be maintained if the duration of the fixation is done appropriately. Whenever the nucleic acid is a very important aspect of our analysis, we can ideally store them or fix them at 70% ethanol. This is usually done in the cytology samples. In this particular fixative process, the nucleic acids are more preserved and there is very less nucleic acid degradation happening. Further, there are few considerations which have to be taken into account. The specimen thickness. Specimen thickness should not exceed 4 to 5 mm. There is a need of proper percolation of the fixative into the tissue. If the specimen is quite thicker, then the fixation may be differential and the inner tissue may not be fixed properly. Especially, the decalcification process is very important. If nucleic acid testing has to be done in the future, which is obviously a must, ETA sample should be used for decalcification, and acid decalcification should be avoided. So this is a very important fixative process. I can have next slide, please. Regarding the fixative timing, fixation in the formalin should not be less than 6 hours and should not be more than 36 hours. So 6 to 36 hours is what we are looking at. Anything which is overfixed can cause degradation of the nucleic acid, leading to fragmentation and sequence alteration. And this can give erroneous results, especially the interpretation of the next generation sequencing fragments actually. Even the underfixation may have issues for technologies like immunohistochemistry and in situ hybridization. A minimum of 6 hours is a must. Next slide, please. So the tissue processing should be also standardized. There should be a proper protocol automation so that there is a uniformity in the way the tissue is being handled. And the importance of paraffin does make a lot of role in terms of quality. So the ideal paraffin, what we can select is the one which liquefies at a very low temperature. That is the less than 60 is recommended. Next slide, please. Regarding the sequential sectioning is very important. If you see that most of the clinical practice is the initial diagnosis, and then followed by the further subtyping of the diagnosis, which is done by IHC, and then the sectioning is done for the purpose of molecular testing, including the FISH, ISH, or further IHCs, or for genomic testing. So whenever we know that all these sequencing of testing will be required, rather than wasting the tissue for refacing every of the section again and again, more sections should be cut upfront, and then each section should be utilized so that the tissue loss is minimized. So very, very important aspect. And this is pertinent to small biopsies like the lung biopsies, where we know that the histological diagnosis is a must, followed by the molecular testing, which is a kind of a paradigm, which needs all these things. So we will have to make sure that the tissue is not exhausted. So it is ideal to have more sections upfront and without wasting the tissue further. Next slide, please. So this is again the example what I was trying to mention, that reflex cutting of 15 to 20 unstained slides should be done so that you can reduce the sample loss. And couple of slides, maybe approximately 3 to 4 slides are required for the H&E, and then couple of slides for the IHCs. And then you need at least 10 slides for the biomarker testing. And we know that EGFR, ALK, ROS, BRAF, PD-L1, these are the important biomarkers which needs to be done in all lung cancer for that matter. Next slide, please. Micro dissection sometimes is very important in order to have a better yield of your testing. So you can remove the parts which are necrosed or not pertinent for your analysis, focusing only on the tumor aspect rather than the normal tissue for that matter. This can have a better yield, especially when you are using technologies like PCR. Whenever you are using technologies like PCR comparing with the NGS, the sensitivity is relatively low as compared to the NGS. So sometimes the microdissection can increase the yield or detection rate of those alterations which may be missed using the techniques like PCR. On the contrary, if you are using NGS, you may have a better yield. But sometimes whenever the tissue tumor content is low in the whole section, microdissection can enrich the tumor cells, which can have a better yield in terms of the picking up of the alterations. Next slide, please. So now the question comes, after the tissue is being processed, the paraffin embedded block is done, you have to store the blocks into appropriate temperature and humidity so that they can be maintained for long years actually. So ideally, the temperature, it should be dry and it should be at the room temperature. Anything beyond this can have impact on the nucleic acid degradation, and the archival tissue may not be useful for molecular testing in the future. So always look for storage protocols which emphasizes on the dry environment and at the room temperature. Next slide, please. Proper transportation and communication is very important. Most of the time when the transportation is not done properly, the specimen is rejected, and which may have implications, especially the transportation which may involve a lot of barcoding, a lot of labeling. So appropriate specimen labeling is must. Incomplete requisition or information can also lead to rejection of samples. So it is better to have the demographics complete, the clinical information all clean, and also the information if you can provide like the cold ischemia time or type of fixative or the duration of fixation for that matter. And also avoid inappropriate workflow, which can lead to tissue wastage. So all these things can really help the yield in terms of the quality of the results, which we are very much looking forward to. Next slide, please. So there is a publication which comes from India, which talks about the practical recommendations from a panel of Indian experts from Dr. Rajiv Kumar Kaushal, and which talks about the optimization of tissue handling and processing in the era of precision medicine. So I'm going to just talk about the key highlights of this particular review article. May I have my next slide, please? So just bear with me. It will be more of a so optimization of the tissue handling and processing in the era of precision medicine. Expert opinion on the cold ischemia time. Tissue must be fixed immediately to avoid rapid deterioration of DNA, RNA, and protein. Cold ischemia time should be minimal as possible and not to exceed more than 1 hour. Ensure the training of nurses trainees, technologists on proper and prompt fixation of the tissues and maintaining cold ischemia time below 1 hour, maintaining a record of time of administration of anesthesia, and removal of the specimen may be submitted to the pathology department as a part of the detail of the specimen. Timing of beginning of the fixation should be recorded. So these are the important aspects. Now let's go to the important expert opinion for the type of biospecimens. Formalin fixed paraffin embedded specimens are the most preferred specimen for biomarker testing. We all know about it. And the tissue storage as it increases the shelf life of the tissue to several years. So we may require this tissue later on. So we have to store it very well. Separate standardization and validation needs to do and for each type of specimen. Cell block should be prepared whenever feasible. Whenever you have the cytology samples or fluids, just spin down the cells and make the cell blocks. Next slide, please. Now, the opinion on the tissue fixation. We have already discussed the best buffer or the best fixative is the 10% neutral buffered formalin at a pH of 6.8 to 7.4. The date of preparation of formalin should be recorded. Freshly prepared formalin is always preferred. And recommended to mention the expiry date on the containers used for biopsy sample collection. That is within 5 days of preparation. So if it is more than 5 days, a freshly prepared formalin is recommended. Fixation time should be recorded and controlled. Recommended time in formalin, at least 6 hours is must for small biopsies, 12 to 18 hours for large specimens, and fixation beyond 24 to 36 hours should be discouraged. But we are not recommending that it cannot be done, but more than 36 hours is a big no. But 24 to 36 hours is what we discourage. So ideally, between 6 to 18 hours is what we are aiming at. Particular care should be taken regarding fixation timing for procedures conducted before a weekend or a public holiday, as it may lead to overfixation and can impact the molecular results. Special care should be taken for transportation time. If a sample is to be transported to a referral laboratory for further testing, as its likelihood of overfixation increases. The pH of formalin should be mandatory checked daily, and if it is less than 6.8, it should be discarded. Formalin fixation of tissue specimen at 4 degrees leads to better nucleic acid preservation. If fixation is done at 4 degrees, in-house standardization and validation are recommended not only for routine histopathology or IHC evaluation, but also for molecular diagnostic assays. Acid or heavy metal fixatives or decalcified specimen should be avoided for biomarker testing. Specimen dimensions are equally important. Tissue sections thickness should not be more than 4 mm. Volume to mass ratio at a minimum, preferably 10:1, with the tissue completely submerged. So the fixation volume should be enough. Next slide, please. Opinion on the tissue processing. Optimum processing time for core biopsy should not be less than 3 hours for smaller tissues and up to 16 hours for large tissues. Prefer dehydrating agents like isopropyl alcohol. Use standardized automated processing protocols, and manual tissue processing is not recommended. Details of tissue processing conditions should be recorded. The solutions in the automated tissue processor must be changed periodically as per the manufacturer's recommendations, and the record of the same must be kept in the laboratory. The tissue processing quality should be evaluated by checking the histomorphological features in addition to optimal DNA RNA yield. Now, the opinion on the biospecimen requirement for molecular testing. Only trained technicians should handle all the small biopsies. It is recommended not to club all the tissue cores into one paraffin block. At least 2 separate blocks should be made. One meant for histopathological diagnosis, and the other is meant for the molecular workup. It is recommended that highly purified wax, paraffin wax, which melts at less than 60, should be used for tissue embedding. Review all the available pathological material together so that unnecessary repetition of the same test is not done. IHC should be performed when deemed necessary.
it should be used or performed judiciously. Reflex testing is preferred over sequential testing, and blocks should be cut at minimal number of times. Tumor fraction should be maintained at more than 10% of DNA extraction. Microdissection and macrodissection can be performed to enrich the tumor content. So next slide, please. So as just discussed, the expert opinion, but let us see a couple of more aspects of the optimizing the tissue handling. Whenever you are looking for the histological examination or H&E test, the section, minimum 3 sections are required of 3 to 4 micron actually. If you want to know or you want or plan to do IHCs on those tissues, then you have to have more sections. And if you are going to have molecular testing and yes, then at least 4 to 6 sections of 10 micron thickness or 15 to 20 unstained slides are used. So you have to just make sure that 3 to 4 microns meant for H&E or IHC and 10 micron for the NGS testing. So this is just to tell that yes, we can have thick slides so that we have enough tumor cells for the analysis. Similarly, whenever you are doing testing like FISH or PDL1, you should have minimum of the available cells. For FISH, we need minimum of 50 cells so that we can report it properly. Similarly, for PDL1, we need 100 cells or the tumor cells or the available cells in the specimen. Next slide, please. So the importance of pre-analytical error was quite evident in this trial called PROFOUND trial, which was done in the patients on the metastatic prostate cancer. And what they found that the analysis which used the identification of the HRR genes using the DNA extraction method followed by NGS, they had a lot of failures. And the failures could be categorized into 3 major categories. The major category was the DNA extraction failure causing a lot of insufficient DNA yield. That is, the quantity of the DNA was not sufficient because most of the tissues were the archived tissues, or they were the tissues taken from the decalcified bone. So this is something which is very important. Sometimes the yield of the quantity of the DNA gets compromised. Similarly, the quality of the DNA was also not adequate for a lot of times. That is almost like 122%. And you can see that even after the extraction was done, the quantity was not good actually. And then we had similar percentage of pathological failure, that the tumor content was not there. So either it was exhausted in initial analysis of H&E, or the biopsy was not taken properly in terms of the quantity of the tumor was aimed at. Next slide, please. To summarize today's discussion, the accuracy of molecular testing can be compromised if the quality of the specimen being analyzed has been impaired by inappropriate processing and handling. The integrity of specimen cannot be retroactively recovered once lost. It must be safeguarded upfront by rigorously controlling the critical pre-analytical variables. Expert recommendations to be followed, which will help in minimizing the pre-analytical errors. So with that, I would thank all my experts sitting with me. At the same time, the audience who are listening me at a lot of strength and patience. And I hope that I conveyed the message clearly that pre-analytical are very, very important. We have 5 major aspects to take care, and each aspect needs detailing. You can have your own lab protocols, internal protocols. You can train your technicians to ensure that they are following those protocols well. You can have your own quality practices where you are documenting each and every step so that there is no miss. And training of your staff regularly makes a very important aspect or very important point in terms of maintaining or the continuity of the quality for that matter. So with that, thank you very much for your kind attention. Over to the organizers.
Thanks, Dr. Amit, for the wonderful and enlightening session on pre-analytical aspects of lab medicine. Now we will move on to the panel discussion. But before that, I would like to inform all the audiences here is that due to some medical emergency, Dr. Ram Prasad could not be able to attend this webinar. And in place of Dr. Ram Prasad, Dr. Suruchi will be moderating the session. So just a quick introduction about Dr. Suruchi. Dr. Suruchi Agrawal serves as a head of scientific affairs at MedGenome Labs, bringing extensive expertise in human genomics. With a Master of Science and a PhD in human genomics, she honed her skills during her tenure as a postdoctoral fellow at ACTREC, Mumbai. Dr. Agrawal plays a pivotal role in liaising between clinicians, pharmaceutical partners, and B2B clients, offering both pre-sales as well as post-sales technical support. A sought-after speaker, she actively engages in continuing medical education sessions, webinars, and conferences, contributing insights on genomics. She has been integral part in the development, validation, and optimization of next-generation sequencing-based cancer genomic test, covering both tissue-based biopsy and liquid biopsy. With a meticulous understanding of NGS assays and adherence to global guidelines, she has been personally overseen the report of over 10,000 cases. With over 11 years of experience in oncogenomics, Dr. Agrawal possesses a profound comprehension of cancer biology and the associated biomarkers. Over to you, Dr. Suruchi.
Thank you, Dr. Firoz, for such warm introduction. And I thank Dr. Ram as well as MBI Association for providing me this opportunity. I thank Dr. Amit Verma for such a comprehensive overview of pre-analytical errors that we have to take care while using tissue for NGS processing. So moving to the panel discussion, I'll just would like to share my screen. Is my screen visible?
Yes, ma'am, it is visible.
Thank you so much. So now we move on to the panel discussion, how to minimize pre-analytical errors. We have a very distinguished panel today. We have Dr. M.V. Chandrakant, Consultant Medical Oncologist, Narayana Super Speciality Hospital, Kolkata, India. We have Dr. Sharad Desai, Surgical Oncologist, Mahatma Gandhi Cancer Hospital, Maharashtra. We have Dr. Shivakumar Swamy, Senior Consultant Oncoradiologist, Healthcare Global, Bengaluru. We have Dr. Lavanya. She is a Senior Scientific Officer at Indo-American Cancer Hospital and Research Institute, Hyderabad. Dr. Divya Midha, Consultant Pathologist, Tata Medical Center, Kolkata. And Dr. Meenu Angi, Consultant Cytogenetics, Unipath Specialty Laboratory, Ahmedabad. Welcome all and a very warm good evening. So we'll move on. So I'll just set the context, like what are we discussing today? Basically, Dr. Amit has comprehensively highlighted that we have to be very careful for the tissue material that we use for molecular testing. And this is a slide, this is a screenshot taken from CAP site where they say that the imprecision in precision medicine. So right now we have some imprecision in precision medicine, and which is basically the control of pre-analytical steps that impact the quality and integrity of patient biospecimens from which all molecular data is derived. So basically it's about garbage in and garbage out. So we have to be very, very mindful, careful about the tissue specimens that we use, because they are very, very precious. And there is an invasive procedure involved to obtain them, and how we process them, it is a very important step for molecular testing. So just to set the context, there is a case scenario where patient with metastatic lung cancer underwent biopsy late on Friday afternoon, and the sample was placed immediately in 10% neutral buffered solution. The adequate volume of fixative was used. However, sample was sent to the lab for further processing on Monday afternoon only. So if you see, from Friday to Monday, we have crossed 48 hours window or 72 hours window as well. And if we consider the working day and the actual days, the working day, if we say that, okay, on working days we'll work or we'll process the tissue, then it is just one working day, but actual days, 3 actual days have passed. So this is how we have to minimize these kind of things. And the another scenario where, we have a FFP block which was cut for PDL1 testing following pathologist initial assessment of H&E slides. This scenario was highlighted by Dr. Amit Verma very well in his slides. So PDL1 positive staining was obtained. The report was obtained. However, FFP block was rephased and recut for EGFR testing, which was negative. And subsequent ALK testing was also negative. Now we want to test further for other biomarkers for lung cancer, and we don't have the tissue. So the tissue is rejected for insufficient material. So first question to Dr. Chandrakant. In your practice, you would have received multiple reports in which the result was test failure or insufficient tumor. So how do you see these kind of scenarios as a clinician? Definitely it will impact on the patient treatment. So how do you take care of such scenarios? What is the way forward for the patient? And what is your reaction basically and your advice as a clinician, sir?
So
Thanks, Dr. Suruchi, for that question. Yeah.
So may I request
Yeah,
all
Dr. Suruchi.
may I request all the panelists to please switch on the video, if you don't mind.
Okay. Yeah, everyone are on screen now. So, yeah, Dr. Suruchi, I think clinician, the report that tissue is inadequate after 7 didn't I mean that it didn't qualify the quality requirements. I just hate it. So it's very painful for me as a clinician in a corporate practice we counsel in a very sensitive way. We say that we are hopeful that there is a mutation, we'll be able to give a targeted therapy or immunotherapy. This is the counseling we have. And at the end of 7 days, and you say that it didn't qualify for whatever purpose, DNA, tissue, whatever reason, I just hate it. I just don't want to hear that. I can hear anything. So this is what is the actual state of my mind. So, but having come across this, the tissue failure rate is 50%. That is the amount of failure. Even a randomized trial has reported 50% failure rate, inadequate for all the 12 genes, right? So at least the 12 genes which we look into, so at least 50% of the times it is not adequate. So what I have done, what modifications I have done in my practice to overcome this, number one, I communicate it with the intervention radiologist. They do a PET guided biopsy, from the hot site. This is one. The site of biopsy is to be decided. Number two, I tell them to take adequate tissue, whatever cores, someone takes 6 cores, someone takes 8 cores, whatever, adequate tissue. This is the second thing. And thirdly, I counsel the patient that maybe you may need 2 or 3 biopsies. Hopefully with 1 biopsy, we'll be able to get tissue. So I counsel the patient that the tissue may not be adequate and you may need to undergo a biopsy so that it is not a shock for the patient. And then fourthly, I will request the pathologist to report not the histopathology part, whether the tissue is adequate for molecular test on the 2nd or 3rd day itself. That is the adequacy for molecular testing. And then the next modification is I will send liquid and tissue together in almost all my patients. So liquid is false negativity is the problem, because sometimes if it's early stage, less disease burden, it may not shed. But if it's positive, it's wonderful. I can start treatment based on the report. So these are some modifications I have done. So you need to have a coordination with the intervention radiologist. PET is something that I have got into picture. And the number two, patient has to be counseled that it can be negative. 50% chance that you may need a 2nd or a 3rd biopsy. And then tell the pathologist that you say me whether the tissue is adequate or not for all the 12 genes, because even missing a MET or a BRAF is as important as missing a EGFR, or even missing a RET. RET is more productive to inhibit than a EGFR. A RET inhibition goes on for 2 to 3 years, so that changes the landscape. And the biggest problem what I face as an Indian clinician is liquid biopsies of false negatives in Indian labs, I'm really concerned about the false negative liquid biopsies. So, I mean, at an affordable cost, if I can get a proper liquid biopsy, I would be really happy about it. So this is my perspective of tissue as an issue in cancer.
Yeah. Thank you, sir. Thank you. That was really wonderful. And I would like to, understand more on the part that you talk to your interventional radiologist. And how is that? Basically, it is an informed biopsy, kind of hot biopsy. You use some terms, sir?
True. So if you look into different tissues, like let's say liver, lymph node, lung metastasis, right?
Mhm.
Uh, I mean, you need to look into the SUV. SUV is the hot spot in the scan where the viable tissue is there. Like, for example, a low SUV may have a necrotic tissue in that area. So if you poke in the necrotic tissue, you will get very limited viable tissue. So so nowadays our IR guys say that, sir, we will look into the PET and then we'll do a biopsy. We will not do biopsy before that, because the non-representative biopsies have fallen. So again, the thing of what I heard is the pathologist saying that, this is only necrotic tissue, fibrinous tissue, and this is a problem. The patient takes an impression that, अरे तो आपने तो cancer बोला था, अभी इसमें cancer है ही नहीं. So that is the impression they get. They don't understand that a biopsy.
We have lost you, sir.
Yeah. So am I audible right now?
Yes.
Yeah, so they don't understand that a non-representative biopsy. They understand there is no cancer. So these are very sensitive things. So therefore, coordination with IR is very important.
So this is a proactive step. I think this is a very wonderful point to be noted, that this is a proactive step that can be taken to take the viable tissue sample, so that we do not have the tissue which is necrotic or which does not have the tumor content. Thank you, sir. Thank you so much.
Thank you.
And just wanted to highlight, from the laboratory perspective, of course, it is a very unfortunate situation, even for lab and for medical oncologists, for patients, that we reject the certain samples. But yes, we do see FFP rejections in about 13 to 16% of samples. And a majority of these rejections, they fall in pre-analytical criteria with pertaining to the tissue amount, tumor content, or extraction yield and quality, which is about 12%. When we say tumor content, as you rightly highlighted, sometimes we do get a tissue block which does not have the representation of tumor cells at all. Ideally, it should be greater than 20% of tumor cells which should be represented in the tissue block that we get. So that can be salvaged to a certain extent by tumor enrichment by punch biopsies, but that is also possible only for medium or large tissue biopsies. And then we have certain levels of failures at library and NGS data quality, which is mainly because of FFP DNA quality that we get. So I think Dr. Amit also highlighted this, and same thing we have noticed in ProFound trial also, where most of the failures were pre-analytical pathology failures or DNA extraction failure or failure after DNA extraction, which is the DNA quality is not adequate for next generation sequencing. So my next question to Dr. Lavanya and Dr. Divya, basically, how to maximize the use of available tissue. And basically to Dr. Divya, do you at crossing itself segregate a block with tissue for molecular testing, especially in case of lung cancer or GI malignancies if you have multiple bits of tissue? And is there a dilemma on how much IHC testing should be done for the fear of losing out on tissue for molecular testing? So Dr. Lavanya, could you please highlight how can we maximize the use of available tissue?
Yeah. Thank you for the question. What we practice here is to maximize the tissue usage. First of all, where it is a small biopsy or the large biopsy, the fixative time is followed. And after the block preparation and embedding with a good wax and all, then comes the usage, whether it is a small biopsy, and then it is actually divided into two parts, with a larger tumor content for the molecular testing and the lesser for the HNE, morphology reporting and IHC panel. Now, question comes for the molecular testing. When you're trimming the tissue, we try to minimize the reflex cutting is minimized here. We try to take the trim tissue also for DNA extraction, especially for molecular testing for PCR or NGS. And apart from that, we do the sectioning and cutting for the molecular testing at the same time. Like for the multiple testing, like NGS, real-time PCR, if it is IHC or FISH, for all the tests together, we try to trim the tissue or sectioning at the same time so that the trimming is minimized. At the same time, the trim tissue is also used for the DNA extraction. So that gives a better yield. DNA yield is increased in that way for us.
So ma'am, as Dr. Amit also mentioned in his presentation that, we have to keep the sections with high tumor content for molecular testing.
Yes.
So are we all mindful about it in our
Yes,
lab practices?
Definitely. What we do is with the tumor content greater than 10%, which has come for NGS, we keep it for NGS paneling. If tumor content is less than 10%, we go for the small panel EGFR by real time, the IHC, ALK, and FISH ROS. So at the time of the diagnosis itself, it is decided depending on the amount of the tumor percentage as well as the tissue area present in the block, whether it is sufficient for a larger panel of NGS or a smaller panel with other platforms. That will help to save the tissue as well as the testing is at least 50% of the results is obtained. Apart from that, when the DNA yield for EGFR for this single gene testing itself is low, what we do is we try to minimize the mutation testing. We try to do only a driver mutation testing so that at least 50% about driver mutations like deletion in L858R, we get around 90% of that in the EGFR. So we get at least 60 to 70% positivity in that. So when you're doing a mutations also, we give a priority to the driver mutation testing so that results are obtained. By following this, in our data, around 3,000 samples we have done, we could able to report the rejection criteria of the samples has come down. It has increased to 12% of the samples we were able to report.
Sure. Thank you. So the message here is that we have to section the tissues in a way that we are saving the tissue for molecular testing in most appropriate manner.
One small addition is during the cell block preparation, we have added a thromboplastin, which had given us a better yields compared to regular cell block preparation. And the results were really wonderful for the molecular testing when thromboplastin was added in the cell block preparation. And apart from this, we try to do with other platforms also. If NGS, if not NGS, then go for real time. If not real time, if feasible, go for a digital PCR. That will give you better results.
Because it can pick up low frequency mutations,
Yes.
or maybe input is less.
Yeah. We also did a study, concurrent study using a pleural fluid directly for a single gene, where the pleural fluid is directly taken instead of making into cell block. We have done the DNA extraction and we have tried only a study with a real-time PCR. Initially, about 110 samples were done. In that, we have obtained that block versus the pleural fluid directly was 100% concurrent results for EGFR testing we have obtained. And the fluid sample is very good. We have got a DNA integrity is so good that you get a minimum of 3 to 4 CT differences in terms of CT values for the EGFR testing.
So, ma'am, very interesting point actually, this pleural fluid, so the cells are spinned down and used directly for the DNA extraction, is it?
And
or you are putting it in some
No.
RNA later or something?
Nothing. When the fluid
But this will be only possible if it is collected and processed immediately, isn't it? What is
in the sense within 24 hours of receiving the fluid at the room temperature, when the fluid is settled down, we pellet it, and the pellet is stored at 4 degrees. And within when the pellet is stored at 4 degrees for 3 to 4 days, after that you can process for the extraction. And from the pellet, you can also make a smear and see for your and do the staining and see for your tumor percentage also.
Okay. So that's how the tumor percentage can also be known.
Yes.
Like a cellularity kind of determination. So 24 hours, as you said, can be transported. So without any other solution added.
Yes.
Okay. Okay. Or
we had an advantage because it is a hospital based. We could receive the samples
what-
immediately. So
Yeah,
that is how we have done the study. But transporting the samples, I would say you can pellet it and then transport it. That will give a better advantage.
So pellet can be transported at 4 degrees
Easily.
Celsius in chill
Yes.
pack. Okay. Or maybe it can be suspended into RNA later solution.
Depending on the transportation time, you can do that also.
Yeah. Okay. Thank you. Thank you, ma'am. So moving on to the next question, Dr. Divya. Do you at crossing itself segregate a block with tissue for molecular testing, especially in case of lung, GI, and if you have multiple bits?
Thank you, Dr. Suruchi. Thank you, organizers, for having me here. Yes, let's talk about small biopsy first. When it comes to small biopsies, say lung cores, as you said earlier, we get around a minimum of 3 cores from lung tumors generally, and they're of adequate size, 1 centimeter or so. And initially itself, at the time of, placing them in the cassettes, we try to, at our center at least, make 3 cassettes. So a minimum of 2 would be recommended, but we try to make 3 cassettes. And when the HNE, at the time of HNE itself, we, evaluate the percentage in each of the cores, and we keep the one with the more tissue for molecular testing and the one with a little lesser tissue for HNE and IHCs. Regarding big specimens that you're talking about, yes, the ones which are received fresh into the laboratory directly from the OT, especially in case of breast or in lung cancers, we do take a block immediately, and we take a section, put it into a cassette, and place the cassette separately, and that we label it as the molecular block of a small bit of tissue, say 1 centimeter into 1 centimeter of just pure tumor. We just take that and put it into a thin slice into fixative. Yes, we do that. And regarding your second question as to how much IHC testing, is there a dilemma? For lung, particularly since we're now talking about lung, we have to use a minimal panel for diagnosis. So when we know for sure that this is cancer, this is small cell versus non-small cell, that's the decision first. Once we know it's non-small cell, we just do a if suppose you directly see glands, you don't need to do further IHC. Or if you directly see squamous differentiation, you don't need to do IHC. But in case of non-small cell tumors, a very limited panel, TTF1 and P40, should help you. And then we do not really waste a lot of tissue on IHC testing.
Yeah, so again, like proactive assessment of the tissue. On that basis, we can decide how much IHC we have to do, right? Thank you. Thank you. So from the lab side, basically on the tissue insufficiency, what are the salvage steps that we can take? I just put some steps here or some points here. So as we mentioned that we get maximum of 3 to 4, 4 to 5 cores for lung cancer patients, and it is a very invasive procedure. So we have to be mindful. So order of the testing, the biomarkers should be decided judiciously, like which test to do first, and also like sections to be preserved for molecular testing with higher tumor content. We can use broader NGS panel here. I think when we are doing RT-PCR or when we are doing next generation sequencing, the input DNA amount is almost same. So if we choose broader NGS panel, I think we will be able to cover more biomarkers. And we can deplete the block. So this is one thing that we do when we get the block here. Only thing is that the tissue will not be available for any further testing. And with depletion of the blocks, definitely with the consent of clinician and sometimes of the patient as well, we have salvaged about 95.5% of cases where the depletion was required. So among 10,000 blocks, 15% of the tissue blocks were depleted, and 95.5% success rate we have noticed with depletion. So we can perform next generation sequencing on the tissue which is left in the block. Only thing is that tissue will not be available for further testing. And total of 4% samples were rejected due to inadequate tissue. And definitely if tissue is not available, liquid biopsy is suggested in stage 3 or above tumors. I think this we have discussed. So again to Dr. Divya, I have a question that moving on to these factors, why do we face the rejection or the quality-based rejections or pre-analytical errors? So this is about tissue processing, and in tissue processing, fixation is the initial step and critical factor for successful testing. So what is the type of fixative to be used, or in your practice, what is being used like across the centers? Time to fixation, shelf life, how frequently should the fixative be replaced, and what should be the ratio of volume of fixative to the volume of tissue? So your experience and your observations on this.
Right. So the fixative that is most commonly used is 10% neutral buffered formalin. We should always note the time to fixation, and because this is a very important thing, as shown by Dr. Amit also said, the cold ischemia period should be kept less than an hour, and that's very important to note at what is the time we are taking to fix it. And the shelf life should be prepared fresh, and the shelf life should be up to 5 days, maximum 7 days. You should put a label as to when the fixative was prepared. Keep it in containers so that it doesn't convert to formic acid. And the ratio should be 10:1 for sure, and the tissue should be submerged. So 10:1 to 20:1. So this is what we are doing at our laboratory also, and it's important to note the pH also. It should be kept at the correct pH with the help of a pH meter. We check the pH frequently. So that's how we maintain fixation in our laboratory.
Thank you for that, ma'am. Actually, the first slide that I showed, right, in precision medicine. So basically, CAP also highlights the point about compliance. So I would like to understand, like, what is the percentage of compliance to these protocols? We have the protocols, given by CAP and so many studies, but what is the compliance rate to these protocols? And across India, how do you see, these being followed?
Right. So that comes to the hurting point, that unfortunately, when you're dealing with your own hospital, there are a lot of things which are under our own control. We have a good, sort of a communication with our nursing staff. We have a great communication with the technologists. So the time of the cold ischemia period can be kept decently, there, because of the good communication, that as soon as you take out the specimen from the OT, that should reach our laboratory in time. But this does not happen when we are receiving review blocks. So that we have seen a lot of issues with the fixation issues. The review blocks are very poorly fixed on many occasions, and this really gives us a lot of difficulty. Not only to forget molecular, even HNE and IHC is a huge problem. So that sort of is quite difficult. Then coming to the problem of holidays or weekends in your own hospital, sometimes we do face certain issues when the OT runs till very late in the evening. Say, for example, just the other day we had a hysterectomy which ran till 9 o'clock in the evening, and the specimen, it came to us in the morning. And there was a lot of issue with the cold ischemia period. So we had to rely on the prior endometrial biopsy to do all the IHCs as well as the molecular poly testing. So yes, compliance is a problem sometimes, but good communication with your nursing staff, good communication with the technologists, your fellows, your students who are training under you regarding cold ischemia period usually solves the problem. But when it comes to outside blocks, it is very difficult to control these issues.
Definitely. And I think this is the message that, the ground level practical challenges to be mitigated to improve the quality of tissue. And I remember Myriad mentioning that we have to process the tissue in genome friendly way. So basically, we have to understand that it is going to be used for molecular testing further, and it has to be processed for, kind of DNA friendly way. Yeah, so these are some of the papers or guidelines, which say that fixation time is very important, and over fixation and under fixation both is a problem. So 8 to 48 hours, up to 48 hours, most of the guidelines they have suggested. However, for DNA, few papers and few places, it is mentioned that formalin fixing and embedding of tissues for 24 hours and freezing tissues are effective approaches for obtaining DNA of good enough quality for molecular biology analysis. So for DNA, basically overfixation should be completely avoided because it will lead to high cross-linking of bases and thus affecting the quality of DNA. Here also Myriad mentions at least 8 hours, but less than 36 hours is optimal for DNA. Next question to Dr. Sharad Desai. In your regular practice, sir, post-resection, within how much time the sample is transferred in neutral buffered formalin? Who prepares the neutral buffered formalin and how frequently it is prepared in your institute? So we would like to have an insight on, again, probably the compliance and how do we look at the reagent quality. Am I audible?
I'm sorry, I was unmuted.
Sorry.
Thank you, Suruchi, and thank you, organizers, for having me. And I'm going to talk about from a different perspective compared to all my other panelists who all come from probably metros. I come from a very, very small town called Miraz in Maharashtra. The name of my town was also not put over there. So it's a very small town, and we are practicing oncology there. So looking at all the figures which you have been seeing, I think most of the errors which are there being done are basically human errors, and these can be neutralized and they can be brought down to minimum. So basically, what we do in our hospital is that we have got a very good system. We have a very good communication with the pathologist and the team. And because these hospitals are small, the town is small, and we can give better services than what can be given in the bigger cities. Like immediately, when you ask me about what we do to our biopsy specimens, they are immediately put into the formalin, and we immediately transfer it to the pathologist. The pathologist gets the specimen in just less than 5 minutes. And he usually separates out the specimen and takes it and then he proceeds further. So this is what I know. And we don't rely on giving the specimen to in the hands of the relatives or the ward boys or the IA boys. We usually insist the nurses take the specimens. When it is a small biopsy specimen, there is not much this thing. But most when the histopathology specimen goes, it's usually one of the OT nurse who knows about the surgery and the specimen goes there, and probably if she needs to orient the specimen for the pathologist also, she does it herself. So this is the communication and this is the speed which we do, because I work very closely with the pathologist and I know the difficulties which the pathologists have. So if you take a lot of time, then a lot of autolysis and all that occurs, then you are going to get very bad reports, whether it's histopathology or whether you go for immunohistochemistry.
Yeah, definitely. Mm-hmm.
So
thank you, sir. I
basically
think
what I mean to say that the specimen has to reach the pathologist within 5 minutes.
I think that is very, very important point. We have been, highlighting this point of cold ischemia time, that the resection to formalin and formalin to pathologist. I think if that time can be reduced, and as you rightly mentioned, the communication, the coordination is the key. And I think this is the message that we want to give, that we have to minimize these compliance errors. Sure. Thank you, sir. Yeah, so this was the paper which actually has shown that, in different tumor types, the delay to fixation has actually affected the quality of DNA based, which is measured based on Q ratio or Q30 ratio, we call it basically. So if the fixation time was delayed, the DNA quality was reduced. You can see it clearly. So faster the better, that is the message, and communication is the key. So next question to Dr. Shiva Kumar. What are the challenges while doing the biopsy and how painful the procedure it will be to the patient? I think this is more about the empathetic, like empathy towards the patient, that these are such invasive procedures and we face a lot of challenges in doing the biopsy or rebiopsies to the patient. It is physically invasive. So what are the challenges you face? And after seeing the test has failed, especially from the lung biopsy, what is the reaction and what is the guidance to the stakeholders involved in pre-analyticals? How to mitigate this and how important is it for you as a clinician and for the patient, definitely, who is undergoing the procedure?
Thank you, Dr. Suruchi and the organizers. I hope I'm audible.
Yes, sir, you are.
Yeah.
Thank you.
Yes. So I think when it comes to lung, this is something which what we do because we work in an oncology setup. I think Dr. Chandrakant also spoke about PET-guided biopsies, but we do a lot of PET imaging also, which will definitely help us and guide us in the biopsies. First time is always a good time. We have to keep everything in mind. It's not just about the diagnosis, but we have to keep IFC and other markers, probably even for the genomic analysis, complete panel, all that we have to keep in mind. So we discuss this with the patient a lot, and also the clinician also help us to do all this. Anytime given a choice, I would want to work with my pulmonologist before we do the procedure. If it is a central lesion, I would always ask my pulmonologist to pitch in so that we can minimize the amount of complications. So one biggest thing what we are really concerned about is the pulmonary hemorrhage, which even the patients are really scared of. Almost 99% of the times, these procedures are done as a daycare and also under local anesthesia. We don't prefer to do any sedation on these patients. So pulmonary hemorrhage is one thing which patients are really worried, and even for us, because when we are inside the lung parenchyma, and if it starts bleeding, many a times patients start coughing out blood. I mean, hemoptysis is immediate thing which will further stop us to go ahead with the procedure. That is kind of a very bad experience for the patient also. We may have to call in the code blue team to address, though we take all the precautions right from giving tranexamic acid, all that, but then this is one of the things. Pneumothorax is something which are not really worried about, because we know that we can handle it and the lung will not collapse immediately. I mean, it takes a little more time for the lung to collapse, but pulmonary hemorrhage is something which we are really worried of. But we do take a lot of precautions and planning goes in this. And we tell the patients also, I mean, we may come to a situation where the yield of the tissue may not be adequate. Even if it comes positive, we may not have adequate sample and to do all the panel of tests. And we also tell them that we may have to redo the procedure. Of course, it depends on center to center. With good hands, the yield is always good. But most of the times, especially with the lung cancers or any cancers for that matter, the workup happens in most of the other hospitals. I mean, it's always good that whenever they see a mass on imaging, they bring in everybody and then discuss before we put in the needle. Because the smaller hospitals and even diagnostic centers, prime concern is that they are looking at only making a diagnosis of a cancer. They are not looking beyond that. I think there is no pride in saying that I saw something on the imaging and then I made a diagnosis of cancer and I did an FNAC. I think FNAC is something more or less completely banned in my center. We don't do FNAC for most of the, I mean, except for thyroid, I don't think we do. One or two lymph nodes where we have to prove that it is a metastatic, only such situations. It's always a core biopsy. That, as Dr. Chandrakant said, 6 to 8 cores is the minimum sample what we provide. Yes, this is something which we plan, and in case if there is a rebiopsy, that we do reschedule as early as possible, probably within next 1 or 2 days. lot of discussion happens with the patient, and we try to tell them how important these procedures are. I mean, this is the thing, first step in any cancer treatment. So that is something which even the patients needs to understand. Otherwise, if they think that the complication, and then they may say that no, we are not ready to undergo. We even tell them that if they absolutely refuse to undergo under local anesthesia, we consider them under sedation, get them properly evaluated, and do the procedure.
So right, sir, actually it is indeed a very intricate process for patient as well as for you who does the procedure. So the message here is that we have to be empathetic about it. And then what is your guidance to the stakeholders involved in these pre-analyticals? Because we have to handle the tissue, this precious tissue, very carefully.
Yeah. When it comes to the stakeholders, yes, I think most importantly, once the patient is handed over to us, so we discuss with the pathologist. I'll make sure that the pathologist is involved. We even tried doing some kind of analysis even when the needle is still in the lung, and we asked to do pathologist a frozen section, but that generally doesn't go well with the lung, especially with the lung, because it's very critical. You can't leave the needle inside and then do that. But it's always good, especially for the clinicians and the pathologists, to get involved and tell the patients that these procedures are very important in further management of the whole case scenario. If at all, if we are able to get a sample from outside the lung parenchyma, where there is a big soft tissue from the metastatic disease, we could do that. But primary in the lung, this pulmonary hemorrhage is something which is very important, which we need to take care and then do the procedure.
Definitely. So the communication with the pathologist and patient counseling is important.
Very important.
Okay, thank you, sir. So next question, I would like to ask Dr. Lavanya, what are the challenges faced at your institute? I think from last few years, you have been taking the measures and the steps that has helped you to minimize these pre-analytical errors at your center. I would like you to share your experience and the measures that you have taken at your center to minimize these errors.
Yeah, thank you. Initially, we started our work in 2014. During that time, when the fixative, we have faced a lot of issues where the fixative time was long and the delay was there and ischemic time was not followed. Especially the buffer pH was not maintained, and the wax was actually, due to some reason, when it was changed, we couldn't obtain the DNA. So three main reasons are the fixative and the fixative buffer, how it is used. And now the protocol is like we are preparing the buffer, formalin buffer, every 2 days freshly, and the pH is maintained from 6.5 to 7. And beyond that, after 2 days, it is not used much. And the other thing is the wax. Wax was very, very important for us because of this. In our real-time experience, when we used to get positive for the same sample, it has gone to a borderline cases or a less coverage cases. Because of that, and we have troubleshooted it, it was the cause of a wax. When it was changed, a good quality wax where it can be digested very fastly, that has given us a better yield. So these three main things were there. Apart from that, the main other thing is the section cutting. We don't follow as 5 microns. We try to follow as 3 to 5 micron section cutting, so that the digestion with the xylene is much faster and the yield is better. In that way, and the extraction protocols, especially for the slide review cases which are not in our hands, for the molecular testing, we have changed the extraction protocols, utilizing either modifying the extraction protocol right from the xylene treatment to the incubation, as well as the increasing the elution, DNA elution. It is not like we do only single elution. We try to do multiple elutions so that we get maximum DNA from the column. It is like 2 to 3 illusions we take out so that the maximum comes out, and then we try to do the process. And at the same time, the PCR protocols as well as the molecular amplification protocols are changed so that the coverage is more and the sensitivity has increased for the PCR reaction. In that way, we have changed the protocols. So right from the storage, receiving, fixation, embedding, and extraction protocols for the molecular testing. This actually has helped us to gain. We used to get before modifying these protocols, we had a rejection criteria of around 12%. Now it has come down to 2%. So we hardly reject samples now. Either it can be a slide review cases or in-house blocks. So we follow NGS, large panel and small panel, alternative platform, and the changes in the extraction protocols, molecular testing, as well as the pre-analyticals. So 4 steps we have changed it.
Sure. Thank you. I think that was a very insightful information, and many would be benefited with this. So moving on to, just want to highlight, like as you mentioned, basically when we have low tissue amount at MedGenome, as I mentioned earlier, we'll use depletion and use of more optimized extraction methods. And with depletion, we have a reporting success rate of 95%. And for tumor enrichment, punch biopsies has helped us to salvage lot number of blocks. Then extraction, definitely optimized extraction protocols that we have to do from case to case basis. And as you also mentioned, with the experience, we are able to optimize extraction protocol. And especially on the basis of the site of biopsy, we have seen that, prostate samples usually comes with low genomic DNA size. We did this exercise across the tumor types, and we found that pancreatic and prostate had the lowest genomic DNA size, as we were seeing more failures in these particular tissues. And similarly, when the breast tissue is with fatty content, then again, we have to optimize the extraction protocols for such tissues, and case-to-case basis, I think the decision is taken. And some papers they had mentioned, especially for breast tumors, the tumor should be excised from the fibrous portion of the breast rather than the fatty portion. And as we know that decalcified bony lesions, they are not ideal, and necrotic mucinous post-chemo tissues, they also do not yield good DNA. So my next question to Dr. Divya. What are the common issues you're facing while histopathology analysis of your samples you receive from other centers? And what are the possible causes of errors, and how can we minimize it, basically?
Right. So this what you're talking about is predominantly the review blocks that we get, outside blocks that we get for review
Yeah, or
in-house.
probably even for NGS if you're getting.
Right. So what happens is I can, like, as a histopathologist, I'm not talking as a molecular pathologist first. First, as a histopathologist, I think that it can be broadly classified into 2 types: the qualitative issues and the quantitative issues. When it comes to qualitative issues, we get poorly fixed blocks, we get poorly embedded tissue, they're all scattered in the block. We get poor quality wax. The minute you put it into the, it's cracks. So you have to use a cold water bath. We get ones which have been probably poor quality reagents have been used. The tissue bursts when you put it into a water bath. That's a common complaint we get from the technologists. We get broken blocks. We get uneven blocks. It's difficult to. So these are the basic issues which our technologists come to us and they say, what should we do? Look at the quality. It's a broken block. It's an uneven block. Sometimes when they cut the tissue washes out. So that's another problem. So how do we deal with such things? For poorly fixed, they reprocess the tissue. For poorly embedded, they re-embed it again. For even the broken blocks or for the uneven blocks, or when the tissue is scattered in the block, they try to re-embed and do it again. For poor quality wax, they try to use a cold water bath, is what they tell me. And for washed out tissues, they use a double coated slide, etc. Now, the second big problem, which is the quantitative issue. which is that the outside people, when they send the blocks, they've done too many IHCs. They've run unnecessary. They've done a CK, CK7, CK20, and PAS-D, and the tissue is depleted. So there is insufficient tissue. So that's a big problem. Another issue is too many. So there is too little. There's another problem, too many. They put too many cores into one, and they have exhausted it by putting too many. And putting too many cores also fragments the tissue. So that's another problem. And of course, the problem pointed out by Dr. Chandrakant, he said necrotic, hemorrhagic, mucinous tissue, which can be overcome, I think, by, proper guidance, CT guided, when you're sampling the hotspots or looking at the prior PET CT, looking at the SUV and sampling it. So these are the basic qualitative and quantitative issues as a histopathologist, which I face. When I get too many cores, as soon as I receive it, I divide it into the lab. I tell them, divide it, put them into separate blocks and give it to me. Too little is, of course, a big problem. Nothing can be done. And there's very little control on pre-analytical tissue, on the pre-analytical problems, especially when they come from outside. You don't have any control over it. But we do try troubleshooting in the lab. Yeah.
Yeah. So when you say too many cores, how many are too many, ma'am?
Oh, how many are too many? I think anything more than two in
one block.
One is too many. More than two cores in one block is going to cause tumor fragmentation and core fragmentation. So we've seen this with breast biopsies. We've seen this with prostate. So prostate also, you should have one core or maybe maximum two cores per block. More than that, there is tumor fragmentation. Very difficult to, quantify the amount of tumor as a histopathologist. It's quite difficult to do all that. And then you're wasting. Suppose you're doing IHC, too many cores in one block, you've done your IHC, your special stains, you've finished all your tissue. So that's anything more than two to me is too many in one.
Yeah. So from MedGenome, actually, we have Dr. Koral and Dr. Syed also joined us here. Dr. Syed, I would like to have your inputs also on this. I think we reiterate with Dr. Divya about the qualitative issues that we face at MedGenome. Do you want to add to it? Anything you want to add?
Yeah, thank you, Suruchi. Regarding the multiple issues which we get,
Dr. Syed, your voice is echoing, Dr. Syed.
Yeah, is it audible now?
Yes, yes. We are not able to hear you now.
Is it audible?
Yes, it is audible now, Dr. Syed.
Dr. Diva was mentioning those are the most common issues we too are facing. Usually once we are getting the review blocks from outside, so those are the most common challenges we too face. And broken blocks, and we usually re-embed and make sure that sections what we get for next generation sequencing is adequate.
So we also get the blocks with too many cores, Dr. Syed?
Yes, we do. Only prostate is the one where if it is a sextant biopsy or multiple sectioned biopsies, if you are getting from prostate, that is where we get blocks with single cores, but rest and all multiple cores embedded in a single block.
Sure. Thank you, Dr. Syed, for your inputs. So next, moving on to, I think this we have discussed, but just briefly would like to highlight that, of course, the step of paraffin infiltration that also needs to be standardized based on melting temperature, quality of paraffin, and any other factors. And I think we have certain guidelines that low melting temperature paraffin should be used. It should not go beyond 60 degrees during embedding, and low quality paraffin with metal contaminant should be avoided. And I would not take this up further because I think we have discussed this. Moving on to Dr. Meenu Angi, what are the common issues you face while FISH test for the sample you receive from patients and centers? We have been talking about next generation sequencing and DNA quality, but do we face these issues while we want to do the test of like FISH? And what are the possible causes of errors and how we can minimize it? Ma'am.
Thank you, Dr. Suruchi. Am I audible?
Yes, you are, ma'am. Thank you.
So commonly, while I will start from the sample receiving, sometimes we receive blocks without any histopathological report, and HER2 fish is there in breast cancer, gastric cancer. So no histopathology report is there, and sometimes multiple blocks are there without any histopath report. And after receiving sample, we do examine H&D in all cases. And in some cases, there is scanty tissue, and in some, there are no tumor cells. And in some cases, there are only normal tissue present. In breast, only DCIS component with no invasive component. So all these are the problems when we examine the HE slide, and if the tissue is adequate, everything is okay, we proceed it for the fish. And then we encounter the problem in the signal in some cases. There is suboptimal hybridization or no hybridization at all. And even if we repeat the test, the same result we get. And if we receive 2 or 3 blocks and invasion is there, we try it on another block, the same result is there. And we have to give the report as indeterminate. So we also don't like giving indeterminate reports because we have tested it thrice. So these are the problems, and especially if there is bony tissue, then fish signals are not visible or they are very weak. And in the tissues where eosin dye is used for the identification of small biopsies, in some lab eosin dye is used. If that dye is used, then fish testing doesn't yield any signal and there is the optimal hybridization. So these are the 3 points where signals are not there. And if sometimes the control probe is not visible in HER2 testing, only the signals are there for the HER2 and control is not visible. That is due to background fluorescence. So in these tissues, how can we prevent? The errors could be that because of the weak signal, it can lead to false negative or false positive, false negative mainly reports. And how we can prevent it by if all the histopath report are shared with the blocks, and even time of fixation is written on
So,
those.
yeah, sorry to interrupt, ma'am. So, do you think that hybridization artifacts is due to the fixation could be related to the fixation time?
Yes, because in every batch we have many samples and it doesn't work in one or two. And on repeat also it doesn't work. Repeat testing with another probe also, different company probe also we try. So these are mainly due to pre-analytic factors. Fixation and cold ischemia time is not maintained, or the sample is processed on the weekend, so the fixation was long. And bony tissue are always a problem.
So definitely we are talking about that fixation is very, very important, whether it is NGS or fish. And we have these, how well do you know your FFP specimen, these guidelines where they mention about fish PCR, all molecular testing, the guidelines, how the fixation and other things should be handled. So again, going back to Dr. Divya, as the ischemia time has an impact on downstream processing, is there any sort of constant education on this between surgeons, pathologists, amongst the surgeon? I understand the point about, the effective communication and coordination has been mentioned, but is there any constant education protocols that follows so as to, improve this particular aspect?
So in any hospital, the nursing staff, the OT technologists, even your own lab technologists, there will always be they'll be changing communication, a training system where we educate our nursing staff, our OT technologists, our lab technologists, the new fellows or the trainees who come over about the importance of cold ischemia time and about the importance of time to fixation. So for this, there has to be, so like for example, in our hospital, we do have a teaching program where the nurses are educated, the OT technologists are educated, our pathologists they take classes. Now, but this cannot be a one-off thing that you take something 2 years back and nothing happens. So there has to be a constant training towards the importance of fixation, the importance of recording the cold ischemia period, the importance each time a new fellow comes, he has to be told, or a trainee comes, because the consultants are busy reporting. It's your fellows who, or your trainees who do the fixation job. So they should know as soon as it comes from the OT, they have to go, they have to fix it, they have to record it. So that's very
Yeah, so ma'am, we discussed earlier about compliance. So even if there is a constant education and constant training happening, still we don't see the compliance. Do you have any thoughts on it?
You're right. Yes, of course. So, as I said earlier, just 3 days ago, there was a case where I reported my own specimen to have severe fixation artifacts because the OT went on till the evening. Maybe there was a gap, there was a lapse of communication. The postgraduate waited for a long time. There was no. So, what they could have done was, once the uterus was out, while they were closing and doing all their other procedures, they could have sent it earlier, actually. So the OT got over at 5, but the other thing steps to till 9 o'clock. So there is always a period when there will be a lapse of communication, and this does break at times. So we note these things down. We had a communication with the surgeon actually over a cup of coffee, and we said that and immediately mails were sent and communication was sent to the nursing staff and to the surgeons itself, that whenever you're facing a delay in the surgery, do communicate with the pathology laboratory and send the specimen as soon as possible. So yeah, the warm ischemia time and the cold ischemia time has to be kept to a minimum.
Sure. Thank you, ma'am. So I think the communication and the coordination is the key here. Again, highlighting to the same thing.
And
so
of course,
these are
maintaining a register. Maintaining a register is important
record.
also, so that we have a record. And if there is a lapse, if there is deviations from it, one will have to address it. Yes.
So I think more important is to, talk about compliance, because we have gone through these guidelines or protocols a number of time. Another question to Dr. Meenu. How do you ensure adequate storage conditions? And Dr. Amit also, please do comment. How do you ensure adequate storage conditions so that FFP DNA retains its integrity? I think we have to understand that after the block is prepared, like how do we store it?
I think Dr. Divya can answer this better, because I am mainly doing cytogenetics, not in histopathology.
Sure,
Right.
ma'am, no problem. Dr. Divya, would you like to?
Yes. So the blocks have to be stored in, as was highlighted by Dr. Amit earlier so nicely, at a room temperature, say maintained between 18 and 25. It has to be a dry area. You have to make sure there's not much humidity there, or not under direct sunlight. So at ambient temperature, you're supposed to store your blocks. Sometimes, we do cut sections earlier and we keep them, that we'll do the testing later. Even that period when we are keep those cut sections should not be stored just like that, lying out in the open in the laboratory after a period under bright light or in a humid environment. You should not use those uncut slides after a prolonged period of time for further testing. So even that has to be kept in mind. And of course, a pest-free environment. How do you keep it? It should not be kept in paper boxes or something. So your storage containers, your storage environment has to be ambient. Also, very important is that once you've stored the blocks, you have to have an SOP in your laboratory about block retrieval and block storage, so that you can easily access the blocks when you require them, when there's an order for molecular testing or cytogenetic testing. It should be easily retrievable, the blocks.
Definitely.
So that's another point which I want an analytical phase.
Yeah, proper labeling, proper specimen labeling, and
Yes.
storage.
Yes.
Sure, ma'am. Thank you so much. Dr. Amit, would you like to add anything to it? I think, next question for you. Do we have Dr. Amit with us? So, yeah, I mean, obviously, this paper clearly shows that the age of the block actually reduces the quality of the DNA that we get. And the age of the block reduces the quality of the library, NGS library. And the age of the block reduces the average read depth. And as Dr. Divya mentioned, not only the age, the storage protocols can also affect these parameters similarly. So we have to be again careful in storing the blocks, how we are storing it, what is the temperature, plus the age of the block. If the blocks are very, very old, the NGS ideal age should be within a year or less than 3 years, but beyond 3 years, we have seen the failure rate of about 50%. And here in this paper, it was clearly mentioned that it is recommended to store FFP blocks at lower temperatures instead of room temperature to prolong storage time. So in case we want to prolong or we want to store the FFP blocks for longer period of time, the temperature should be reduced to 4 degrees Celsius. So my next question is to Dr. Amit Verma. Am I audible, sir, to you? I mean, I just want to see whether he is there or not.
Dr. Suchi, I think Dr. Amit is not available. Maybe you can ask Dr. Lavanya.
Yeah, or maybe Dr. Chandrakant, I would like to ask. Any particular advice at this very outset for the clinical team involved in obtaining the tissue, sir? And I mean, do you suggest like fresh tissue or RNA later or snap freezing? Or any place for touch imprint for assessing tissue yield? And we have to remember that we are in a molecular era. So over to you, sir. Dr. Chandrakant. Do we have Dr. Chandrakant on the panel? You are on mute, sir, if you are able to hear me. Okay. Dr. Lavanya, could you please take it up?
Yeah. See, for the mostly as the diagnostic sample is preferred on the FFP tissues, it's better to always process it, fix it, and embedding is taken care, and the storage of the blocks as emphasized before, it's better to store at the ambient temperatures. And especially I want to add one point is for RNA extractions, it's always better to store the blocks at 4 degrees so that your yield is better for a longer time. And other way is if you are planning for further testing on molecular, you can preserve the DNA and RNA extracted from the FFP blocks at -80 so that you can utilize that samples as well, where the retrieval of the block might not be possible or there are issues with the tissue if doing a next step. So you can also use the nucleic acids for further testing in future also. So that also should be preserved. That is the point I want to add on. And using of RNA later and snap freezing will come next when fresh tissues are taken into account. RNA later is good, but the way the tissue is stored in RNA later differs a lot because we have to actually gradually store the tissue in RNA later. First, when it is the tissue is dropped in the RNA later for storage as a preservative, you should first keep it at 4 degrees, then -20 and then -80. That will give you a better preservative for the tissue. This is my experience because I've used RNA later. So that is the reason I know that. And snap freezing at -80, the fragmentation of DNA is higher. So I better prefer that when you're using for a fresh tissue, use RNA later in a proper way of a storage. And the best tissue is the FFP blocks. If not FFP blocks, the DNA obtained from the FFP blocks can also be used.
Yeah, I think that is a very important point highlighted that if we are not able to store the FFP blocks, we can actually isolate DNA and RNA and store those molecules for further use.
Yeah.
And yeah. And regarding RNA later, like you mentioned, definitely RNA later is good, and we have observed 100% success rate for molecular testing for both DNA and RNA when we have received tissue or cells in RNA later. However, there are certain challenges that only a part of tissue can be put in RNA later solution. Rest of the tissue has to be sent for routine diagnostics, because once the tissue is put in RNA later, routine diagnostics cannot be done. Plus, we don't know the tissue bit that has been put into RNA later, whether it has enough tumor content or not, or what is the histopath or IHC examination cannot be done on that particular bit. Then the accessibility issue is there, like where the resection is happening, do we have handy RNA later solution available? Because tissue has to be directly put into RNA later solution. And these are some of the challenges that we face with RNA later, but definitely the quality of DNA and RNA that we get is good. Yeah. So this is another, like Dr. Divya also mentioned, and Dr. Meenu also mentioned about it, that we get a lot of blocks sometimes in the lab. So which block to select? Ideally, it should be pre-selected by the pathologist, those who are sending it to the lab for molecular testing or for cytogenetic testing. Tumor tissue content has to be assessed, and the blocks having, enough tumor tissue content should be sent, particularly the quality of the blocks. So again, from Dr. Meenu, I would like to understand this. Like when so many blocks are received at your lab, I think you highlighted also that you do H&E on both the blocks. So what is the message that you want to give?
So in all cases, like if the blocks are less, like we are not facing this problem in all cases. Some centers are providing us all the information, even writing the fixation time, providing everything. But where we are not having this, we do the HE staining and we select the block. And in the block where the maximum tumor is there, we mark the site, and then on that probe is applied. And we know that what are the findings in histopathic examination, H&E slide, and based on that, we see the FISH results. And tumor tissue content is very important for the NGS-based testing. So at the same time, the sections are taken for NGS testing also. If ALK testing is for cytogenetic and EGFR is for them, so the tumor content is written on the notes that how much tumor is there. If it is less than 20%, there can be chances of false negative report. And regarding pre-chemo biopsy versus post-NSC section block, I have a discussion with one of the my colleague who is reporting histopath. She told that in nowadays after post-NSCT, the tumor is difficult to find. The test rate is so high. So pre-chemo biopsy should be preferred. And ideal to take fresh biopsy in the ASCO-CAP guideline. For breast cancer, if there is a metastasis, that repeats biopsy should be taken from the metastatic site, and the biomarkers should be tested on that.
On that, yeah. Yes, definitely. Dr. Syed, would you like to add to it?
Yeah, which block to select is with, obviously it should be with higher tumor content. Ideally, anything more than 20% is the ideal one. At our center, we have standardized it to 10% and above. Even 5 to 8% with complete depletion, we have had a good yield and diagnostic yield.
Yeah.
And with respect to pre-chemo or a post-NSCT, ideally pre-chemo is the ideal one, whereas if it is post-NSCT, we will have excess of necrosis and a lot of post-CT changes, as well as a viable tumor will be lesser if it is. And with respect to fresh biopsy or a metastatic site, especially ASCO-CAP has recommended to even test mainly on a metastatic setting, where even we can pick it up even subclonal new evolved mutations.
Definitely. So from metastatic site, we expect the diagnostic yield will be better than the primary site because it will have some more additional acquired mutations probably. So that is why it is recommended. Yeah, so I think we have discussed this. So next, this is a very important point, and I think this is a kind of a few of the last points that we are going to discuss. So we have to basically optimize the procedure to get the maximum yield of DNA for genomic tests like next generation sequencing. So there has to be like platform selection, best reagents for extraction, quality control, EQUAS programs that we participate in. I mean, to optimize the extraction protocols, troubleshooting, then how many repeat extractions we are doing. I think few points Dr. Lavanya has already pointed out. I would like to understand from Dr. Koral, her perspective as she is heading the lab, oncopathology lab in MedGenome. So what are the platforms and the best reagents, or how do you optimize the yield from FFP blocks for NGS testing?
Hi, everybody. So we have been getting samples from other centers. So already the other panelists have already mentioned that when you receive samples from other laboratories or other hospitals, we don't have the control of how we are getting this specimen. So each and every specimen is given due attention as to what methodology of extraction has to be done. Basically, we have two ways of extraction. One is the column-based extraction, and another one is the bead-based extraction. So the bead-based extraction, usually the yields are good, but sometimes the quality is compromised. But the column-based extraction is the conventional method, which generally all the laboratories use. But in some of the bead-based extractions, the yields are also good with a lot of new methodologies coming up with different commercial kits. The bead-based extraction also gives us a good yield. So the yield is very critical because when we are assessing the sample after the extraction based on the DNA integrity number, and when the DNA integrity number is compromised, that's where the yield plays a very important role, because if the integrity number is compromised, our input DNA concentration, what we take ahead for the next step, will be increased. So we take increased amount of DNA, and we have to enrich the sample at the level of the whole genome preparation and as well as the enrichment protocol, which is the part of the library preparation protocol. So these are the other critical steps where the platforms, what we use for extraction, the reagents, what we use, and we also have certain quality control steps when we are preparing the library as well, where every step is given a due check, and modifications should be done based upon the size of DNA what we have got. And apart from that, when it is coming to the level of troubleshooting the assay, when it has a very low panel average depth or an NGS-QC metrics is low, it depends upon the insert size what we are getting after the sequencing. So when the insert sizes are low, definitely the depth and as well as the coverages are all compromised. So that's when we troubleshoot again and we take ahead re-extraction methodologies. And as you have already mentioned, the EQUAS plays a very important role. And when we are doing a sample which is of good quality, that is a different story. But when we are having a bad quality sample, you always have to assess it with positive control samples and also assess whether we are able to get these samples with the correct diagnostic yield. So these are the things which we follow in MedGenome to salvage samples which are of bad quality.
Mm-hmm. So, Dr. Lavanya, thank you, Dr. Koral. Is there a recommended minimum coverage depth to mitigate damaged DNA fragments to some extent? As Dr. Koral mentioned that, each step has to be quality ensured. So, what is the minimum coverage depth?
Yeah, I see. As an EMK assessor, I want to add up that I've been an assessor for lung for the last 4 years, and I've seen from 17 countries around 450 labs per year. So what here our experience gain is they have a lab developed protocol. The coverage depth to mitigate DNA fragments. The question is, what is the panel they are using, and in each panel, what is the target size they are aiming?
Definitely.
So that makes a lot of difference for the results to be either they are getting good or bad results. Some people we have seen in the labs where they have got only with the 100x coverage area they were getting, they were able to pick up the variant allele frequency with less than 2%. So what makes important is the coverage, what they are deciding according to the labs, how they have standardized their panels with their extraction protocols.
Yeah,
So
definitely.
that is
So
a lot of difference.
Yeah, so basically the standardization of the protocols is important here.
And here one more point, one more point I want to just add on is like compared to the column method, magnetic DNA extraction will give you integrated DNA more. Because column method is a sorting out procedure, and when you do the higher end test with the column method, you will have the background more because of the sorting out. Either it can be a sequencing, NGS, real-time, or a ddPCR. Whereas the purity ratios is very good in the when you follow with the magnetic extraction. Yeah, it is bit longer time, but integrity and the degradation of the DNA will be less with the magnetic extractions. So to answer this fragment issue, it depends. The tissue you have selected, the extraction protocols you're following, the target size of the amplicons you're deciding for the hotspot regions for the panels you're deciding.
Yeah,
So that makes a lot
definitely.
of
So I think input amount of DNA, as Dr. Koral mentioned, also plays an important role. And definitely, like we have to basically optimize the assays based on different quality of tissue blocks that we receive, and that's how we have to decide on certain lab parameters.
One more small suggestion is they can better go like if it is a 200 base pair chemistry, they can go for a internal control amplification test to check their DNA amplification efficiency. That will also, yeah, it is a one step more added on, but that will definitely give you more precision of the DNA quality rather than just checking the integrity with the qubit.
Yeah, I think this
amplification efficiency has to be checked before you're going for a paneling.
Yeah, definitely, definitely. So, Dr. Koral, do we echo with it?
Yes, Suruchi, the amplifiability of the DNA has to be definitely checked because in many times the amplifiability only plays a very critical role when we see that the library level failures are there. As far as the experience, what we have with the magnetic based separation is that the magnetic beads are seen in the extracted DNA as well. So we do a double level of purification when we use a magnetic bead. And based on our experience, we see that we have used quite a different number of magnetic based extraction kits, wherein we have observed that certain kits are not giving that good quality. So we have to actually select the right method of extraction.
That is based on the bead size versus the DNA or RNA you're using.
Yes,
that
you're
makes
right.
an important.
You're right, ma'am. So definitely the amplifiability needs to be checked. And that's one of the critical steps which has to be followed.
Yeah. Thank you. I think that's what we were discussing. And here we see the profiles of DNA with good DIN and a bad DIN. And this is basically the profiles showing the different size fragments of DNA. And here we have got the peak for this particular sample, which is about 2000 to 2500 base pairs. And here all the fragments are below 200 base pairs. So this is how the tape station profiles will give us the DNA integrity number and the quality of basically DNA that is extracted from FFP is kind of monitored. And in our experience, we have seen that most of the samples which are data QC pass, they have DIN of greater than 2. Whereas the ones which are data QC failed or rejected, they have the DIN, mostly they have DIN levels less than 2. And this is what I was talking about. Similarly, we have done for genomic DNA profiles also that I was talking earlier. So in pancreatic and prostate, we see that most of the DNA that we extract is of lower median DIN value. And most of the failures that we see is in prostate tissue samples. Yeah. So I think that's all. So we have few messages here. We have a very important message of, that communication is the key between medical oncologist, interventional radiologist, pathologist, and molecular pathologist. And of course, we have to understand that tissue is an important material, is very precious material, and we have to, all of us have to understand and use it judiciously, comply to the protocols. And this is how we can mitigate some of the ground level practical challenges that we face, and we say that tissue is the issue. We have to move towards saying that tissue is no more an issue, and we should be able to basically mitigate these factors. Dr. Firoz, thank you so much.
Thank you, Dr. Suruchi, for conducting this wonderful, informative, I must say, thought-provoking and engaging panel discussion. I really appreciate your time. And in the interest of time, if you would like to take 1 or 2 questions from the audience, Dr. Suruchi, would you like to take that? I think there are
Definitely,
2-3 questions.
We have a panelists also here. I think can we get the recording and the PowerPoint? PX in low volume labs. How should the fixation of 6 hours be maintained? It will go beyond 12 hours. Is this acceptable? So yes, I think we discussed that fixation time of 6 to 48 hours is acceptable and is recommended by most of the studies. Up to 24 hours is recommended for high quality DNA. How far NGS and single cell genomics is helping in precise diagnosis? What's the main reason in skin rashes in body during recurrent cancer? BRCA1 and BRCA2 gene mutation have greater risk of developing breast and ovarian cancer at the same time or not? What's the reason, ma'am? So I think these questions can be answered separately. Yeah.
Agree.
Thank you so much.
All right. So as we conclude this insightful webinar, it is my pleasure to extend our heartfelt thanks to all who contributed to making this event a success. First and foremost, I would like to express our deepest gratitude to all our distinguished speakers and panelists, Dr. Amit, Dr. Suruchi and team, Dr. Chandrakant, Dr. Sharad, Dr. Shivakumar, Dr. Divya, Dr. Meenu, and Dr. Namru, for sharing your invaluable knowledge and expertise on crucial topic of pre-analytical errors in precision oncology. Your discussion has not only enlightened us, but also underscored the significance of meticulous pre-analytical processes in ensuring patient safety. We would also like to express our sincere appreciation to Dr. Deepak Mishra, President, Molecular Pathology Association of India, for organizing this wonderful event. To our participants, your active involvement and your commitment to learning and improving patient care is truly commendable. Finally, we are grateful to AstraZeneca for their generous support and IAIO for managing this event. As we wrap up today, some of the important key takeaways includes understanding pre-analytical errors from the time a test is ordered until the sample is analyzed. This can include issues related to sample collection, handling, transportation, and storage. We should aim to identify common source of errors and should implement best practices to minimize these errors. Let us ensure that we apply them in our respective field to mitigate pre-analytical errors and enhance patient safety in precision oncology. Thank you once again for your participation, and we look forward to future engagement. Stay safe, stay informed, and continue to strive for excellence in healthcare. Thank you all for your time. Good evening. Good night.
Thank you. Thank you. Thank you so much.
Thank you. Bye-bye.
Thank you.
Bye.
Thanks, everyone. Bye-bye. Good night.
Thanks.